seeing this?
Yeah, let me
The
see.
PowerPoint, you seeing it?
Let's see the chat.
Not hearing them. Okay.
Nobody talking. We're gonna.
Silence.
All right. Hold on a second. Let me see here. Right? Yeah, people they're saying yes. Okay, right. So you could go ahead.
They're seeing the PowerPoint.
Yeah, they're saying it. Yeah,
And they're hearing me.
they're just not using their microphone. So you could go ahead and talk.
Right. I hope everybody is hearing. We can start the lecture.
Like one, if one or two of you could like turn on your microphone, so Dr. Sunarayan could know that you exist. You can't look at the two screen at once.
As we're hearing you and we're seeing the
Right.
PowerPoint.
Okay. Seeing it. Who is primary care doctor by me? I am Tennyson Sunarayan.
Okay.
Believe it or not. No, this is the first time you're seeing me and hearing about me. Yes or no?
Yes.
Right. So we're talking about primary care doctor. Now I want all of you to go when this lecture is finished at WHO website, the categorization of doctors. Categorization of doctors. There's a new category with doctors 1, 2, and 3 now. 3 categories for doctors. The first is the hospital doctor or the clinic doctor, the one that we know, the traditional doctor that works largely in hospital. The second is the public health doctor who deals with crisis like we have now, the COVID-19 crisis. And the third category is the primary care doctor. The primary care doctor is different from the other two. And when you read that website carefully about the characteristics of the primary care doctor, we're going to talk about some of them here, but you will notice that the primary care doctor, the most important thing with that doctor is the relationship between the patient and the doctor and the continued care that the patient gives them throughout their life. So, who is the primary care doctor? They call them different names. They used to call them family physician, primary care physician, whatever, GP. Similar names for the office too. They call them different things in the office. But the common thing is a primary care doctor. And this doctor has to be able to communicate effectively. Communication is a crucial element here. And this doctor here is communicating with a patient as a primary care doctor, close up, eye-to-eye contact, not like the COVID we have now, and using all manner of all available things to communicate, her hands, the way she looks, her facial expression, to make sure that what she gets over to this person and this person can communicate easily with her. So it's easy communication we're dealing here with. What kind of person, some of you who are thinking of going into primary care as a specialty, I am a primary care specialist, and primary care doctors are now specialists when you qualify further in primary care. And the university here now offers it as a diploma in family medicine. You can get your master's in it, and you can also get your DM in family medicine now. I started the program many, many years ago, and it is going on still. And I continue to teach about primary care. Now, the type of a doctor that would make a good primary care doctor, we have the list here. A strong sense of responsibility for the ongoing health and well-being of patient and the family. Because usually the family, all the members of the family come to you also. You have to care. This is a crucial word, caring. The meaning of caring is important. Caring is to have a sense of anxiety over another person's well-being. So you care for another person when you are very anxious about their well-being, and that would define caring. Empathic means you can put yourself in the person's shoe and compassionate sometimes. To be compassionate, if that is happening to you, you congratulate yourself. But it is not an absolute thing for primary care like caring. To be compassionate towards somebody means that you are suffering with them. So that if your mother goes to the hospital, you're kind of worried and going every morning to visit her and so on. You are showing compassion. You are suffering with them. If this is happening to you with any of your patients, well, congratulate yourself. You're human. But then you have to ask yourself whether your suffering with them make you kind of still able to continue objectively and look after them medically. If not, you get another doctor to be involved to help you along. So caring and compassion are the two important words here. You're always curious about what is happening, inquisitive, you ask questions, and you really want to solve the problem. Now, a broad and a keen interest in medicine and the art of medicine. So because you're a primary care doctor doesn't mean you leave the Western scientific biomedicine. That's what we are trained in. You are trained in the University of the West Indies to practice that. And the primary care doctor, the primary care specialist, always practices scientific biomedicine. You don't get into kind of alternate medicine and herbal medicine and that kind of thing. So this is important. We always practice the scientific medicine. And the next thing, since medicine is always changing, we're always updating. So, like, we always keep updated with what is happening in medicine. And a good website that you can write down is WebMD. It's a good website, but another good one is MNT, Medical News Today. Like you can check it every other night or so to see what is going on in medicine, the new things in medicine. So you have some sites I've been telling you since the start. The first one I told you about was the WHO categorization of doctors. Please get that and read it carefully. Now, very supportive of children, their growth, their development, and to recognize disabilities. So always asking about child development. A lot of children come to us as primary care doctors, and we have to be very supportive of them. But children, of course, get afraid of doctors because of their experience with immunizations. I wish there was some other way to immunize children where they wouldn't have to stick them. But that's how it is. So they fear you once they see the stethoscope. So you have to make an additional effort to get a good relationship with children so that they wouldn't mind coming to you. Eager to establish wholesome relationship with patients, with families, and you must know about the social network because you have to know about where they live and their cultural and social circumstance. And dysfunctional families, you have to do family counseling as we have so much violence now. And sometimes the whole family comes to you and they all share in the consultation. The doctor, we continuing the characteristic of the doctor, the ability to maintain composure and think clearly. So when an emergency comes to you, you don't panic like the patients. But if a heart attack comes in, you have to be composed. And you have to think clearly because you have to do the correct thing. And since you are the first doctor they're coming to with their problem, you have to be very good at picking up early clues to diseases and sickness. And you have to distinguish between what patients want and what they need. What they want is what they're asking for. Like they might come for a sick leave, but they have abdominal pain, but they need to check that abdomen, that it continues to pain them. But they might not mention that to you. So you always have to distinguish what they want and what is their real need. You have to like to teach The reason for this, those of you who were teachers before and like teaching will find primary care is good for you, because you're always teaching the patients about their illness. And interest in people. If you don't like people, well, sorry for you, in the wrong business. You have to have strong interest in people and a good sense of humor, of course. Right. Here we have the doctor here and the patient. There is smiles exchanging, there is close contact, there is eye contact, and there is good communication. And that establishes good relationships. So important. And you're always committed to the person, not the body of knowledge, nor the disease, or any special technique. So unlike a specialist who is concerned with a bone specialist only with bones and so on, you are the whole person. And you always try to understand the context of the illness. So somebody come by you with a cut because a dog bite them. You get the story, you know? And you get the story how they were walking outside and the dog rushed them. And then they continue to tell you about it. And then you get to understand that the neighbor dog bite them and they and the neighbor had a big quarrel and he's always quarreling with the neighbor. You have additional problems there. The dog bite, sure, you treat it and you treat the cut or the bruise or whatever. But you now concerned about the relationship between this person and the neighbor and the person's anger. And you will have a problem there because anger is a risk for heart disease. So you have to make a note when you hear the whole story about this anger. And you have to bring it up again when they come back to find out if they're settling down and so on. So you're always seeing patient contact for prevention and health education. So you have primary prevention, secondary and tertiary prevention. Primary prevention is when you tell people, well, general things you tell people about exercise and so on, and eating properly, getting enough sleep, that's primary. Well, you tell everybody that. Secondary prevention is when you are examining them for a particular illness, like when you do a blood sugar test. That is a secondary prevention action you're doing because you're looking for diabetes, or you check somebody's blood pressure, you're looking for hypertension. That's secondary prevention. You're always doing also tertiary prevention. That is when somebody already have an established illness. They're already sick with something, but they keep coming to you and you're checking for complications of that problem. Like they keep coming to you with diabetes, you make sure that the kidney is always working properly. So that's tertiary prevention. And as we said, you're a good teacher, so you're always educating your patients. Okay, if anybody want to ask me a question, you got well stop me, you know. Now, this is the doctor, primary care doctor, and I put this slide here to show that we are also street doctors because we work with the street people. And we're always on the street, probably visiting homes. And to see people because you are the first contact doctor. But remember, although you're the first contact doctor, remember that in all over the world, the first contact doctor can easily treat over 80 to 90% of the presenting illness. So 80 to 90% of your patients are just sent home with treatment. And you only refer about 6 to 10%. So the hospitals where they spend the most money on, the government usually spend a lot of money on hospitals and ICU and fancy machines and all that. They really only look after about 6 to 10% of the sick people in the population. So they're spending the most money to look after the least amount. So the question is, why isn't it not reversed? If the primary care doctors and the health officers are seeing most of the sick people, why not spend more money there? And this has always been the question and always been the challenge. And nearly every country understands the importance of primary care because this is what medical science is now teaching, the crucial importance of primary care. They have to be able to spend more money on the primary care centers. And they are doing it now. Sometimes some of them have exercises and classes and so on. So you view all your patients as a population at risk, and you are part of a network of supportive and healthcare agencies. It's better, as second to last one, to share the same habitat as the patient. So as famous primary care doctor Whitney said, you live where you work and you work where you live. So it is important to be able to, because when you share the same habitat, you identify with its social and cultural circumstance, and you understand their social situation. So that's important, and they know you. For instance, well, if I can take myself as an example, I lived and grew up right where I have my office. So a lot of people know me growing up, and they're now coming to me as their doctor. So I practice right here. The important thing to know about that is that is very different from specialists because you can get a specialist in primary care to come and work in my office from, say, England, but they would not be they would not give good service as I can, having born and grew up here and been with the patients all the time. But you can get a specialist cardiologist or a specialist cardiac surgeon to come from any country. They don't even have to speak the language, and they can do excellent work being a cardiac surgeon in this country. And right now we have a specialist cardiac surgeon who's from Italy doing very good work and doesn't speak English too well either. But that patient, he's not in contact with the personal life of the patient. He's just seeing them when they're comatose and cutting their chest and changing the arteries and so on. So that's the difference. Again, a difference between the primary care physician and the primary care and the specialist doctor. Primary care physicians share the same habitat as the patient, preferably, and then identify fully with the social and cultural circumstances of the patient. And of course, as we said, you see patient, office, home, street. Right, and here we have the primary care doctor chatting again. Now, the primary care doctor is trying always to understand and improve yourself with respect to personal values, beliefs, religion included, attitudes, worldviews. So you have to keep updated, and you always have to examine yourself, what kind of a person you really are. So being a primary care physician, if you want to be a good primary care physician, you always have to be introspective. Who am I? Why am I here? Am I doing a good job? Is there some way I can improve myself? And you have to understand your personal values. You have to understand your belief and your religion. And your religion is supposed to support you in the care that you're giving. If you have a religion that tells you everybody's stupid except you, well, something wrong there. And your attitude towards other people have to be positive. Your worldview has to be positive. And you have to know what perspective you get. You probably have, say, a perspective from childhood where you have racial bias. And that's a wrong perspective. It's probably something you get from your home. And you have to examine yourself. And you have to change that perspective. And that is called adult learning, where you're now learning as an adult to change a perspective that you have from childhood. And being racially biased is one such perspective. And when you change, you would have learned as an adult. And now you can go back to your parents' home and try to change them because they have a wrong perspective. Try always to identify and remove personal prejudices, as we said. Right. Now, the concept of the wounded healer is important. And we'll talk a little bit here about it. The wounded healer. Important concept. More and more people are talking about this, and there are books written about it. And it's a good attribute for a primary care physician. They said the primary care physician should be wounded so they can heal. People who have personal wounds help better patients who have wounds themselves. So when you examine yourself, if you have a personal wound, like people, doctors who find themselves in a wheelchair and unable to walk, they are excellent doctors in the rehab centers because they can personally identify with all their patients. And that's excellent. Now, you don't have to have a physical wound, and doctors who are diabetic look after diabetic patients well, who are hypertensive. Doctors who have heart disease look after heart disease patients very well. So that's a wounded healer. But it does not have to be a physical wound. It could be a mental wound that you have something happen in your childhood and it has affected you deeply. That wound, instead of it making you retreat into yourself and don't want to be with anybody, you always use your wound to help others. So that wound that you have, when you examine yourself, you examine your wounds, that wound you have, use productively so that you can help others who also have wounds. The concept of a wounded healer, you can check it also in the internet. It's an important concept in primary care. Right. And you're always trying to enhance relationships. So every consultation should be finished. When it's finished, the relationship between you and the patient should be enhanced, not made worse. And always aware of how your person and your attributes can contribute to the relationship. And especially you're concerned when you have serious illness in a family. So if the father is in hospital, remember the other family members might come to you suffering with stress and anxiety. So you have to look after this family while they're under the stress. And death in a family is something you always make a note of in the card. So a girl come by you and her father died recently, you make a note of that in a card. So when she comes back next time for whatever she comes, you ask how she's coping and how she's going and so on. So you always note deaths in your card of family members, and grave sickness you note too. So whoever in the family comes, you inquire about it because you would tend to forget, of course, you can't remember everything. So you write it down in your cards. So we have here like a summary. It's important to note. Compassion, caring, empathy, assess. Committed to Western biomedicine. Keen interest in it. And of course, this keen interest you have to keep updated. Okay? And you are a street doctor. So my office, for instance, is very close to a street. So and you're always interested in putting a symptom complex into its context to better understand the illness. Never dismiss people, never tell them to talk in stupidness. You allow people to talk, huh? Very good. So we'll go now to the other. We'll take a little 2 minutes break and we'll get the other one for you. We'll have another lecture and then we'll have a 10-15 minutes break and we'll do the other section. So we take a little 5 minutes here. Thank you. Annual, the next one. Question and answer, medical ethics. Tell them a little 5 minutes.
Okay.
Next one. So this 2 this morning. Late.
All right, so the next one is answering the
Yes.
this one. So when you're going to start back?
5 minutes.
Oh, okay, give them a break. All right.
Then you get a half hour break here.
So it is the ethics Q&A.
Q&A.
Q&A. All right. Well, it should be shared. Well, when you come back, you actually put on a microphone so you could I go in. Call me if they say they can see it.
Where you'll be?
Yeah.
Right.
Yo, they got something to raise up the laptop. It looks like it's too low.
Boy, I have been long way, so.
Yeah, I know. There's something to look at that.
Yes. Right. You hearing me? Somebody say yes.
Hi, yes, we're hearing you.
Everybody back on?
And they could
Yeah,
send
we're
it.
still here.
You can see the PowerPoint.
Yeah.
Okay, cool. Yeah, go ahead, Daddy.
Right. So this now is that first lecture was on primary care. The most important thing I told you there was very at the beginning where you look for the WHO thing in your internet, categorization of doctors 1, 2, and 3, and you read carefully the characteristics of category 3, which is the primary care physician. So you have homework to do. Now the second lecture is really about medical ethics. And you may be asked in either on oral examination or written examination, a question in ethics. You can be given a problem. For instance, a young girl coming for an abortion by you, which happened to me just a few days ago, 2 days ago, does not want a pregnancy, and you have to, how you handle it. And then that is an ethics question. That is not a biomedical question to say it's clinical question. That is a question in medical ethics. So once you ask a medical ethics question, either orally or written, this is an idea of how you handle it. Okay? Why medical ethics? Well, medical ethics is because medicine has encroached in so many aspects of our lives. Medicine is involved with so many things in our lives. Relationships, it's involved with that because poor relationships can even lead to murder and death. Bruises, poor relationship can lead to anxiety, depression, and it enters into our medicine enters into our social circumstances, which can leave us in poverty and get us more ill because we cannot purchase medicine. So if medicine has entered into all these aspects of our lives, what is good, bad, and ugly, and by way of behavior, your ethics, is crucial to understand. A doctor has to understand what is the proper thing to do because you very often have to advise patients on how they can handle themselves. So you might be given, as I said, a ethics question. Terminal patient requesting an end to life. A dialysis patient say they want to be in front because they have too many people waiting. And you will be asked to discuss the ethical issues involved and how you'd manage this consultation. It's a big challenge. So this is a guideline on how to approach the answer. Always remember something here, and that is that ethics, medical ethics, makes us a professional. Now, there are three professions in the world. We are professionals as medical doctors. There are only three professions. Medicine, being a lawyer, is a profession. And the next profession is being a clergy or cleric, man of religion. Only three professions. Those are the three professions. What marks the three professions things? One, they always are guided. These three people always are guided by what is ethically correct to do. So they're all guided by an ethical rules and regulations. So you should go now to one task you have to do for me is you can go to the medical board right here in the compound, and you can ask for your book on medical ethics. There are copies there. If you don't want to do that, well, you can go here on the internet and you can type in Medical Board of Trinidad and Tobago, and you can read that booklet in the internet also. Two things you have to read there: the duties of a doctor and the ethical guidelines. So the two things that mark profession so far is one, three things mark it. One is that you are guided by a set of rules and regulations. Lawyers, doctors, and clergy. The second thing is that we are guided also by a body of literature. There's a body of literature that guides us. In our case is, of course, the medical science and so on. In lawyers, they have their laws and regulations, and in clergy, they have their Bible or what have you. And we always try to do good for the patient. That makes you a professional. But the third things that guide you, and it's a strange thing, but this makes all professionals, this is a mark of all professionals, is that we can only be controlled, or we can only be told what to do by another person in our profession. Nobody else can tell us what to do. So if we managing a patient, the Prime Minister can't come and tell me how I should do it. It's only a senior doctor in the same profession can advise me. So we are guided by other people within our profession, not by people outside the profession. So how do you answer the question? You answer the question by remembering the first 6 letters in the alphabet. Those of you who remember your alphabet, A, B, C, D, E, F. I wouldn't go on, I would stop at F. And you use each letter to remember these words. And you can put a paragraph for each one. You have to discuss in that answer autonomy issues, beneficence issues. You have to discuss compassion and caring. You have to discuss do no harm, equal care, fairness, and justice. Now, and you could also talk about fidelity and veracity. Now, autonomy is a principle, so you can put P by that one principle. Beneficence is a principle of medical ethics. Principle of medical ethics. 2 of them there. Compassion is a virtue, a V, in medical ethics. Care is a virtue. So we're doing principles and virtues. We have 2 principles here and 2 virtues. Do no harm is also called non-maleficence. Non-maleficence. And that is a principle. You must do no harm for the patient. Equal care, you give to each patient who have similar things, similar care. You don't kind of separate your care from one person to the other. You give everybody equal care, whatever they can pay you or not pay you or whatever. Equal care. This is both a virtue and a principle. Justice, you teach people, you treat everybody in a just way, what they deserve. And that's also both a virtue and a principle. Fidelity is telling, being faithful too. I'm sure all of you know what infidelity is. Well, fidelity is being faithful to. You understand, being faithful to that patient, always faithful to them. Whenever they call you, you answer, and so on. You're there for them. And veracity is always speaking the truth. That's important to know, although sometimes the truth may hurt. You always have to stay on the side of being truthful. So that's how you set your answer. Right, let's do autonomy. It's an important one. The definition is what you do in autonomy is you always respect the patient's autonomy. Always have great respect for the patient's autonomy. And what you mean by the patient's autonomy? You mean the patient's capacity to think, the patient's capacity to reason, and the patient's capacity to decide for themselves. And also their ability or capacity to act on their thoughts, decisions, and reasoning without encouragement or hindrance. They will do it for themselves. So you have autonomy of thought, autonomy of will, and autonomy of action. 3 autonomy things. Thought, autonomy to think, autonomy to act, to want to do it, and autonomy to act on it. So a lot of politicians have autonomy of thought. They can think well. They always want to do it, but when they get in power, they have no autonomy of action. They don't do it. Wow. But you must remember these 3 aspects of autonomy: thought, will, and action. And that's the definition of autonomy. Now let's get to the next slide. Hey, I have to get to the next slide. Right. Hold on a minute. I need a little help here. Manuel, a stick. I want to get to the next slide and I can't get to. Just disappear.
We need disappear. We do.
I don't know. Oh, it disappeared. Oh, there it is. What's your type? Slide share?
No, yeah, no, it's still sharing.
Right. So we continue. Sorry about that. It is important an autonomy again, thought, will, and action. Especially when you're dealing, say for instance, you're dealing with a fetus. Somebody come to you and they don't want that child. The child doesn't have autonomy. The child cannot think, cannot will, and cannot act. But anytime you have somebody lacking autonomy, so if you have a schizophrenic member of your family or family, that person lacks autonomy, they're not thinking straight and so on. Whenever you have somebody in your office, this child is in your office but in the mother's belly. Whenever you have somebody in your office who lacks autonomy, or whose autonomy you cannot respect, and you cannot help them, you always ask them to bring what is called a surrogate, somebody else to act on their behalf. So the mother here will be acting on the fetus autonomy. The mother can act on the fetus behalf. And doctor must respect their patient's autonomy, but a patient might not be fully autonomous. But if you can move them, a consultation must always be to move patients towards greater autonomy of thought by teaching them. Greater autonomy of will, you move them towards that. You make them more want to do something. For instance, stop smoking. You must try to increase that will. And when they go home, they have to act on it. So you're always trying in a consultation to move patients towards greater autonomy. But you have to decide the level of autonomy the patient has. And you have to make a decision on that. If you cannot, although you're trying and you cannot respect a patient's autonomy, it's better you don't carry on the consultation. You call somebody else or you tell them to go home and bring somebody else who can talk on their behalf. So you might have a schizophrenic coming to you alone without medicine and hallucinating and so on. That person should come with somebody else who you can talk to. Now, although you respect a patient autonomy, let's say this mother comes with this fetus and she wants an abortion. Right. The mother is speaking on behalf of the fetus. The fetus has no autonomy. But she wants this fetus terminated, killed, or whatever. Now, respect, and I respect her autonomy. I have a respect for her because she's thinking and she's okay. But that don't mean I have to fulfill her demands. Because I am also an autonomous individual and I make decisions also. So if you cannot do it well, tell her sorry about it and so on. And this was this famous case, Teriyaki. This was the patient Teriyaki. She was brain dead. She was being sustained only on life support for over a year. But her parents, this is her mother here with her. The famous case, it was in Time magazine. Her mother used to visit her, her father used to visit her, but her husband left her. When this happened, he left and he went to some other state in the United States, or to somebody else and so on. But the doctor wanted to pull the plug under her, and she was not autonomous, of course, so they had to ask the nearest person to her. And the doctors in that case went and called the husband. And he told them over the phone, yeah, only go ahead and pull the plug now, and they did. So when the parents who were closer to her in the last year came to visit her, they found her dead. They said that the husband gave them permission. But that was something wrong also. Because the husband was not the closest person to her at that time. It was her parents. They should have been consulted. So autonomy, you have to be very careful how you handle situations. This is a Teriyaki case. It became quite famous. And we're saying with autonomy still, it's important. A patient has some autonomy. This is none and this is full. And nobody would say no autonomy, you have to get a surrogate. But a patient come with you at some level along here. So you always try to push them towards why. Your consultation is always pushing people towards why. Nobody has full autonomy. We don't have full autonomy, none of us. So we have to know that. A child alone in your office or mentally, nobody has. But these people you can't really respect now, so you have to use somebody else, as we said. There are two ways to live your life. One is as though nothing is a miracle. The other is as though everything is a miracle. And Albert Einstein said that. No, this is first order and second order autonomy. I made a statement just now that nobody has full autonomy. So you want to go home, you want to go out one night with your boyfriend and your parents tell you no. If you are exercising first order autonomy when you go leave and you go, forget them. But you're a young girl, you're not married, and your parents telling you they don't want you to leave the house at night. You have to make a decision whether you are obeying your first order autonomy and stoops with everybody else, or whether you should respect second order autonomy. So you decided to respect second order because you have to listen to your parents. And you slam the door and you get vexed something and you lock up yourself in your room and you call the boy and say you can't come. You are now exhibiting second order autonomy. So autonomy is extremely important in general practice and in our lives. But nobody has full autonomy like he believes he has. I will drink 8 glasses of water every day. I will exercise for 30 minutes every morning. I will take the stairs instead of the elevator. I will bicycle instead of driving. I will flap my arms instead of using an aeroplane. So nobody has full autonomy. Important in medicine is the most important principle, to respect a patient's autonomy. And healthcare is always to improve patients' autonomy. Right. Second principle is to do good. A doctor must at all times do good for the patient. You always do what good for the patient. But the problem here is that sometimes what the patient want as their good, or what they see as their good, is not what you are seeing as their good. For instance, the man who came by me in the throes of a heart attack, cold sweating, holding his chest, could hardly breathe. I know he had both hypertension and diabetes and overweight, and he was a risk for heart disease. So when he walked in, the diagnosis was easy to make. So I put the aspirin below his tongue and telling him about the urgency of the situation and that he has to go to hospital. He wasn't speaking properly, but he said, "Doc, I'm not going any hospital. Just give me medicine, let me go home. I am not going to that hospital. I'm not going. I don't like hospital." I had a problem there. I didn't know what to do. So I believe that in the pain, as I said here, a patient may not be in a position to determine his good because of the pain stress. So I called him, I told him to send his wife, or his wife was there with him. So I turned to his wife, who I knew well, I knew the family well. And I said, "Madam, he really has to go, I can't, although he's objecting. The better thing to do at this time, I have to act on what is good for him." So the wife said, "Doc, I'll listen to you, I'll take him, don't worry about him." And he went to hospital and he got better. But the story did not end. Going back to the previous slide. The story did not end there. He went to the hospital and he got better. He got his injections, streptokinase, and so on and so on. He improved. The ECG showed a heart attack and so on. But the day he was discharged, he and a nurse got into some argument about something about the toilet. And he started to argue with this nurse and quarrel with her. And while he was quarreling, he dropped down and he died with another heart attack. I always remember that case because 2 days after, the wife came telling me the story. And you know what? She turned around and told me, "Doc, the man was telling you he didn't want to go and you still sent him." What is the good to do? We always have to weigh that carefully. What is good versus what the patient thinks is good. And sometimes we might be wrong. Beneficence. Whenever you're doing any research project, you always have to make sure it meets ethical standard and is good. And fee-for-service can do a lot of harm for patients because it's not good for some of them because they can't afford it. And fee-for-service over the years can make you have a way of practice that is not good for the patient because you are there only to make money. And you're only making money and you keep calling them back for stupidness. And you're giving them injections because you charge them more for that. And you keep telling them to come back and you hide what is wrong with them and you aggravate their illness. So they get dependent on you. Anytime you be a fee-for-service doctor like myself, you have to examine your reasons and what you charge and make sure that you are not making fee-for-service the reason you're there. And you're always looking after the good of the patient because you are tormenting poor patients especially. And the strange thing, the ironic thing about it, poorer the patient, they might not have as good and they might not have a good understanding what is good for them and what is not good for them. So a lot of poor patients go by expensive doctors because they believe expensive doctors giving them the best medicine, which is not true. And they are intimidated by these doctors. And when they pay these doctors this set of money, they get even more poor. And poverty brings more illness, and they get more ill, and they keep going, and they're spending money. That is the medical profession taking money for people. That is stupidity that should never happen. Whenever you get into private practice and to charge patients fee, you are obligated always to examine yourself. Keep that fee affordable, reasonable. Never call back patients just because you want them to pay you again. Fee for patients is always a problem. No, beneficence is good for the patient. Beneficence is the principle to do good. Now, obligatory acts we must always do. I told you about going to the medical board and getting that booklet on medical ethics. Or you sign on to MBTT, Medical Board of Trinidad and Tobago, on the internet and get it there. Now, when you read that book, you will see listed there what is called duties of a doctor. Read carefully those duties because that's your obligatory acts. That's what you are obliged to do. To do good extra, you must always try to move a little above that towards B, where you try to do a little extra than is required, especially if you're working among poor people or among people who are in need, or you have a patient who is in great need and not able to afford care and so on. You have to kind of stretch yourself and do extra. So your circumstance, your worldview, your religion, the social circumstance, and so on, all this influence how far you go towards B. But when you're at B, you're at Mother Teresa level, and you have to ask yourself how far you can go. So the patient asks, you send them to the hospital. They can't afford your visit, that's fine. You send them to the hospital, and now they turn around to ask you for $100 borrow to go. You have to make a decision how far you will go with them. But always you have to have tension towards B. Supererogatory acts are these great acts, sacrifices of personal time. But all primary care physicians, that you have to make personal sacrifices, time and money, and answering your phone even in the night. You have to tell your family that you have to make these sacrifices. And especially in times of community crisis, like we have now COVID-19, you can't close the office, I'm afraid. These patients need to talk to their doctors to be with them. And you're careful where there's situations where the healthcare delivery system is not just, where people don't want to go to hospital because everybody has quarreled with them in the hospital. And where people have extraordinary circumstances. For instance, disabilities, confined in bed. You have to make that personal sacrifice even greater. But that, of course, depends on how far you go, depends on you as an individual, your beliefs, your religion, your circumstance, your relationship with the patients, etc., and your individual assessment of the case. So how far you go to supererogatory acts depends on all these things, as we said before. Now, without doing compassion, I told you the definition of compassion, to suffer with and caring. So when next time your boyfriend or your girlfriend tell you, I care for you, and you don't know what it means, you turn around and you say, so what do you mean by you care for me? The person will reply, that means I am always in a state of anxiety over your well-being. So you have explained to the boyfriend or girlfriend what caring means. Compassion you don't owe to everybody because you suffer with this. You personally suffer. That's okay. If you are personally suffering, you can continue to look after the person. That's great. But if your compassion is preventing you from doing that properly, well, get some help. And we're talking about empathy, pity, mercy. Mercy. Pity is a kind of looking down. You don't get too much in that. Mercy is what we have to get in. So when a patient calls you out in the ward and says, Doc, have mercy, what they're telling you is to fulfill their needs. Mercy is fulfilling people's needs. High tech, when you go to the hospital, all this fancy machine and things tend to isolate people as individuals. They're connected to so much tubes and machines. You forget them as a person. So more high tech, you have to get more involved personally with the patients. All these are relational issues. So the science and the technology can come between the doctor and the patient. Right. Going to the next slide now. Something stick. Hold on, I'm going to get some help again with this. Manage the slide stick again. Manage it stick again. I don't know why it keeps sticking.
Wait a minute, you can't click on it?
I'm clicking, but it's not coming on. I wanted to do this other one. I wanted to do this one here.
Why it keep going up and down? So?
I don't.
Where now this thing?
Right, I passed all these already. I finished all that.
Right.
It's not coming down.
Which one you reach?
Go down more. Go down. I reach this one.
Oh, okay. Hold on.
No, this one here. This one.
This one?
Yeah, what had happened there?
I don't know. Well, when you want to change that, you just press down. So
Okay, and that might work.
up, or up,
That might work better.
down, or up. Yeah. Well, I don't
Right.
know. I don't know what's going on. The program like glitching out.
Okay, we now come. Sorry about that. You must do no harm to the patient. This is a principle. It's called non-maleficence, as I said before. That means doing no harm. And this is a principle in medical ethics. So we're doing principles and virtues. This is one of the principles. We did autonomy, right? And we did beneficence. Now we're doing non-maleficence. This is above all, a doctor must not do harm, but medicine is trouble sometimes. Because, for instance, surgery, you have to do harm to do good. You always have to wait, whether the good they're going to reap in the long run is worthy of the harm that you're going to do them. Because, I mean, the classical case I always give as an example is a lady, a 48-year-old lady going to the hospital clinic, gynae clinic for fibroids, and the doctor telling her, leave that alone, no worry with it. When your period stop, the fibroids will shrink, and your fibroid's not that big, you don't have to cut it, and so on. And then she went to the very identical doctor, but in his private practice. And the minute he see her, and he didn't recognize her in the clinic, he thought he didn't know her. He didn't know that he spoke to her already. When he examined her, he looked at her and he said, Madam, you have to do an urgent operation. You must take off that womb. Now the doctor had two different views because in his private office he was going to make a lot of money. So his good was to make money for himself. But that surgery would have done a lot of harm, and it was not could have been left alone. So you have to be very careful, especially when you're making money in medicine, whether making the money is interfering with your judgment. And that happens far too often in medicine. You have to be careful whether what you're going to do is the long run, would it do harm or it could. And this was the classic case in World War II when Hiroshima city was bombed by the Americans. The Japanese were already losing the war. It was the end of World War II. Hitler was dead already. And the fight came between Japan and the United States after Pearl Harbor. But Japan was already losing the war. They had resorted to suicide bombers and all that. But then Roosevelt had died and Truman had taken over as president. Truman got a note that the atom bomb was ready. Scientists sent him a note, we're ready to detonate this thing. And he took a decision to bomb Japan. An advisor told him, sir, that bomb will kill thousands and thousands of people. Don't do it. He said, why? He said, because we can't kill all those people. They already lose the war. So this advisor told Truman, let's just go in an island near to Japan that has nobody living in it. Let's just explode the bomb and show them the power we have so that they will surrender. Truman looked at him and said, so if we do that, they will believe that we are afraid to kill them. And he took that decision to bomb Hiroshima. He killed over 100,000 people with that bombing. 1 mile radius flat was completely flat in Hiroshima, a very busy city like Port of Spain. It was no soldier city or anything, an ordinary city, children going to school and everything. And then when he didn't hear from the Japan leaders for 2 days, he called a meeting again and he said, why they're not surrendering? Don't they know what we can do? So then he said, I wonder if they believe we cannot do it again. And then he bombed Nagasaki, killed thousands and thousands and thousands of people. That was doing no harm, really. That harm was not the harm done was too great for the good that could have been achieved. We have to be careful of doing no harm because, as I said, harm may be done to others. Like a HIV patient coming to you and don't want their partners to know. So medical education and avoid doing harm to patients. Yeah, you'll read that. Not going into that. None doing harm. We have to know medicine itself does harm, because there is a book written by a Latin America theologian called Medical Nemesis. And it showed that how medicine itself, the whole establishment, can do a lot of harm to people because of what is called doctor's hubris. Hubris is excessive arrogance. Don't ever, ever make medicine make you an arrogant person believing you're above everybody else. You would become a doctor because your duty now is to serve others, a servant of others. Don't believe you're reaching some kind of pedestal where everybody's stupid and you're alone great. And that happens too often with medical education. And the medical hubris, you start doing harm to patients. Just diagnose them to put them in a class, treating them so you could isolate them in the hospital, connecting them with all kind of devices, and patients feel very disconnected. And more you specialize, more you objectify patients because you're only dealing with one part of their body. And the poor is tormented, especially. And no wonder people turn so much to alternate medicine because medical profession as it is now can do a lot of harm to patients. Equal care, the principle and the virtue. You always treat people equally, similar care. And to do this, you have to be, as the last sentence there, continuing medical education. You treat people who coming to you equally. You don't discriminate. Like you treat all diabetics the same and so on and so on. But the next thing, equal care means you have to be equal to what other doctors are doing. So if you give somebody a wrong injection and the person dead or something, and they bring you in court, the magistrate wouldn't know too much about the medicine. What the magistrate would do is call another doctor of high standing in the society for the case. And the magistrate would turn to this other doctor and say, if you get a patient who come to you with back pain and couldn't walk, would you give this injection? Mr. or Madam, if that doctor answers no, you're in real trouble. Because what you have done there is not equal care. So be very careful that you stay with your medicine, stay with your Western bias scientific biomedicine. Keep updating and do equal care for your patients and for your equal care to the other doctors, of course, also. Justice is again both a virtue and a principle. Justice is it's both general and particular. General justice is righteousness and is a virtue. Treat people just. The definition of justice is you treat people according to what they are deserving. And people deserve the care, they deserve to get better. And healthcare is concerned with justice as a virtue. So you must be a just person. It is also concerned with something called distributive justice. Especially people who are doctors who are in a position to decide how the healthcare system should run. You have to ration it. Rationing healthcare. All healthcare has to be rationed because we don't have money for. You have to ration healthcare because we don't have money for everything. And you have to know who's going first and second and third and so on. And you have to make a decision how you're handling that. And that's called distributive justice. And this one, forget that for now. This is what I'm talking about. Each person should be treated according to their deserts, that particular justice, general justice. And the distributive justice is this one. If you have a long line of people waiting for dialysis, for instance, how do you decide who come in first? You might say who has the greatest need. But the person's greatest need might be a 90-year-old person. Whereas you have a child waiting for dialysis. So who's making that decision? In Trinidad, too often we decide on who is coming first by their merit. So the Prime Minister come to visit you in casualty. Wow, first person you're seeing is that person. That's merit. But that's not always correct. And a lot of people bring in their family and they get merit, of course. And they forget everybody else and they treat that person first. A lot of people say effort should be used. In other words, if the person is making an effort to get better and listening to you and so on and making an effort, you treat them, you give them care. For instance, you tell somebody to stop smoking and they did stop and so on. The effort is great, so you put them higher up. People's effort cannot always be, used because people in high positions easier to make this decisions about healthcare. For instance, it's only when Obama became president he could stop smoking. So effort is a difficult thing for poor people. Contribution, we solve a lot of problems in medicine by contribution. If you can't pay, well, sorry for you. So we set up hospitals and we charge people. And when you go to a private hospital, it's so nice and quiet and neat and everything looking so great because the vast majority of the population cannot go there. They can't pay this. Treating everybody equally, sure. And this has been decided by a lot of people. Anybody come. So equal care means like how the United States Embassy decide who getting a visa first. It's a lot, like a lottery system. They just reach out into this thing and reach out at random. They select names. That's giving everybody equal care. But then the name you select somebody who don't need that at all. So how you decide how you distribute care, and that is why you have to have a committee, medical ethics committee, and you can use one or two or all of them and make their decisions from the committee level in distributive care. Right, we wouldn't get into this. But rationing here is important, huh? And everybody ration care, no matter how your country is, care has to be rationed. And you know what is the meaning of rationing? It means that some individual who need care would be denied, strange. But that has to happen sometime. Well, all countries. But of course, you don't ever discriminate to all this thing. And in Trinidad, where we have this two-tiered system, private and public health, they have discrimination. Because who have money can go to the private care and get. And they're meeting the same doctors who quarrel with them in the hospital, treating them as angels when they enter in the private healthcare system. You don't let money determine your attitude. Your attitude and your treatment of patients should be fixed, caring, compassionate, and being a servant of all, no matter how much whether they could pay or not. Poverty is real trouble. And as a medical doctor, you always have to pay special attention to the poor. You understand the poverty trap. People can't get out. Because especially when they spend more money by doctors, they get more poor. So they're in a trap. And you have to understand also the trap and the cycle of poverty. So even if you get a rich person in your family, like you have somebody, you suddenly get a child who's making a lot of money to bring into the household. The cycle of poverty might not be broken. Because if that money is being shared by everybody, the poverty trap remains there. And poverty is linked to substandard healthcare. Because the health officers would have a lot of poor people going there, and there's a lot of substandard care that can go on. And fee for service, poor people are especially tormented. And the thing to realize in medicine, that all illnesses are more prevalent among poor people. So poor people tend to get more ill. How just is fair is to be born is not just, not fair. And especially community doctors and general practitioners have a special obligation to the poor. And a special obligation to practice the principle of beneficence. And as a doctor, personally, you have an obligation, as we said, towards the poor, especially if you're a primary care physician. And your personal journey in life must never be an upward mobility for self. Your personal journey in life must not be an upward mobility of self. But always, especially as a primary care doctor, your journey should always be a downward pilgrimage and towards people. Pilgrimage is a spiritual journey, a downward spiritual journey towards people where you will treat them and you serve them as a servant. Right, so this is moral reasoning. Now, we said, let's get this thing straight. Hold on, let me get some help here. I think I need help again. Manuel, the thing stick again. Hey, this thing giving me trouble.
Yeah. That's a bad laptop.
Is the laptop in it?
No idea. Wait, why are you taking up the whole screen now?
I don't know.
I don't know.
Go down to
How you managed to do that?
slide number 17, I think.
17, oh God, hold on. I don't know why this program keep blinking over and over. It's probably the screen share doing that.
Where is 17 is where
Yeah. Just use the arrow. Just
no,
use the
no,
arrow.
it's not more than 17 now.
Just use this now.
Okay.
Just to go down.
We did that already.
Just wait for it to load after you press the button, or else it'll go past the slide.
We did that. We did that. Poverty, we talked about poverty. Right, major moral reasoning or appeals.
Yeah.
We have to answer your question. You always think about when we answer your ethics question, what are the consequences if I do this and the consequences if I do that? And then you also answer your question, as we said, from using the alphabet. And they have to know your right, your duty as a doctor and the rights of the patient. And then you always have to think about virtues, yours, and whether you're treating people equally. So we have that as the second thing. And I want you now, we're going to take a little 15 minutes break before we start the other one. So we can meet here at 20 past 11 again, okay? Are you hearing me? Somebody reply.
Yes, we're hearing you.
Yes.
Right. 20 past 11, we'll meet. You can have something to eat. A lot of you, I'm looking at you and you're all looking hungry. So go and get something to eat. 20 past 11 now. Get what I told you to do as research. You have to go into WHO website, classification of doctors, get the modern version, they updated it. You have to go to the medical board and get the medical ethics booklet. And you have to read therein the duties of a doctor and what is expected of you as a medical doctor. You must be aware of these things. And when to answer the ethics question, we just went through those things, how you approach the answer and so on. So I'll see you at 20 past 11. And I hope you're looking like, I hope everybody's wearing a mask. I don't want to get this COVID thing in. So put on your mask and come back with your belly full. So we'll talk at 20 past 11, okay?
Okay.
Bye.
Hi. You might want to mute your mic as you go away for the break. You could click the little mic at the bottom of your screen. So
Okay.
just turn off the audio for the break.
Meet you and okay then. Manuel, just click the mic so there'll be no audio at the break. The mic, so there's no audio. Yeah. I'm going to meet them again at 20 past 11. About 15 minutes.
All right. Okay.
Just say quickly. I'm going to eat something.
Click that. All right, click the next one next to it. Press share video. Hold on. Wait for it. Yeah, press share video. Right,
Here now.
right, so okay, we're back.
Doctor-patient relationships.
Right, somebody just say if you could see
What? You seeing me?
Yes, I can see you.
And you
Okay.
hearing me?
Yes, we hear you too.
Right.
I'm
Once,
not
once,
sure if the last presentation with the 37 slides, we didn't have that one. We had the one prior to that with who is the primary care doctor. But we didn't have the 37 slide one. And we have this one that you're presenting here now as well. The doctor
okay,
patient
so
relationship.
you can see this
no,
one.
and that one is available in the department. You can get it from them.
Okay, thank you.
Just tell it's available. It's in the computer in the department. I thought you all had it.
No, just we have two. We have the who is the primary care doctor and the doctor patient relationship, but we didn't
Do
have
you
the
have one called What is Primary Care?
no, I don't think we have that one. The two that we have are who is the primary care doctor and the doctor patient relationship.
Well, we're going to do what you could get that from the department. The second lecture I did.
Okay. Yeah,
The
the
one
second
on,
one.
yeah, we'll get that from the department. They have it there.
Okay, thank you.
Now, are you all ready? You ready or not?
No, just use the arrows now. Don't,
Right. Okay, just use this.
just use the arrow,
Okay.
yeah. Just press
Right.
once.
Everybody's here?
Press once. Don't hold it down.
Yeah,
Just
well,
press.
Everybody have mask, check. If you wear a mask, I don't have to wear mine, you see. Right. We're going to do a lecture on doctor-patient relationships. Now, remember when we defined the primary care doctor, when WHO defined it and they revised the definition, I think it was 1992. And 1998, they made another definition of categorization of doctors. In doctor number 3, who is the primary care physician, the most important word that they keep using all the time is the relationship between the patient and the doctor. And this is important in primary care, as this slide shows. First contact care, because you're the first doctor the patient would be seeing. So therefore, your interaction with that person would tell whether you're staying within the biomedicine or you're trying to run from them. So it's important to have a good relationship. Now, the doctor is the health manager. The primary care doctor is the health manager. So even if, like I do, refer people to specialists, like somebody come with a fractured femur or something, I have to refer to a bone specialist. But when that patient goes there, they come back to me with the letter from the specialist for me to continue care. Because I'm managing the care. I manage it to the extent that they came to me first. I saw it fit to refer them to a specialist. And that specialist know that they have to send them back to me to continue care. So I am managing the care at all times. As we said, high level of socio-economic and contextual issues, lifestyle issues, whether they how they run their life and so on, smoking, alcohol, drinking. They said 2/3 of your patients who come to you as a primary care physician, 1/3 has only mental issues, 1/3 has only physical issues, and 1/3 has a mixture of mental and physical. So therefore, 2/3 of your patients have some mental issue problem. You care a primary care doctor and you're not concerned about people's mental health, state of mind. Anxiety, depression, paranoia, whatever phobia they may have, whatever problems they have in the family that is interfering with their life. Crucially important, especially in primary care. Always centered in the family, because all the members of the family come to you. And you have to be very careful, of course, if they don't want you to share information, that you do it, that you listen to the individual members. And when they come as a family, you talk to them This is continued care. Now, continued care is not continuous care. For instance, if somebody go to the hospital, every day the specialist will see them and they'll get better and so on. Let's say they had gallbladder surgery. So the specialist giving them the care for gallbladder surgery and then send them back home. So they had continuous care while at the hospital, but their continued care has always to be with the primary care physician, because they come by me for different episodes of illnesses or different problems throughout their life. So, and their children come by me. So right now I'm looking after children, adult who having children, but when that person was a child, I looked after them too, probably in their mother's belly also. So it is continued generational care, and everybody knows you as their doctor. Countertransference is more prevalent. What is countertransference? Countertransference, first let's deal with transference. Transference, the phenomena is a psychological phenomena called transference that happens in a consultation. This happens when the patient, transference we're talking about, when the patient sees you as their father figure or mother, and all the feelings they had for their father or mother, they transfer to you. So they see you just like that, and they transfer all their feelings they had for that person in their life to you also. So they also have the same feelings to you. That's called transference. Countertransference is when it happens from the doctor to the patient. The patient reminds the doctor about somebody in their life or some other patient, and all the feelings the doctor had for that person, they transfer it to this patient. So for instance, if that doctor grew up in a family with an alcoholic, and they hated this alcoholic brother or sister who destroyed the family and so on, whenever that doctor faces an alcoholic patient, all that memory would come back, and they might transfer all the anger and hatred towards this patient. That is called countertransference. And they would treat that patient badly. And we have to be extremely careful as primary care doctors about countertransference. There's a high level of trust and a high level of compliance issues, of course. Right. Now, we said children are very common, and also common in your practice is the elderly. But children come all the time, but they are fear doctors because of their immunization experiences. So you have to get 2 children via some other means. And this doctor is listening to the Dolly's heartbeat first. So what I do, if the child is on the mother's lap, I kind of put my stethoscope first on the mother, in her hand, in her head, and all about. And then I gradually bring the stethoscope to their chest that I really want to listen to. So you have to kind of play and make them comfortable about the situation. Now, this is doctor and patient relationships. This is what the lecture is about. This slide shows doctor and patient in the middle there in red, and the responsibility coming from the left and empathy coming from the right there. With the red you're looking at, to the top right, you have communication skills. Crucially important to enhance that relationship, as we said. You must always have an inquiring mind, because if you don't inquire, you wouldn't know the situation. That's crucial. The patient must have confidence in that doctor, and that is established after a number of visits so that they can confide in you. And of course, interpersonal skills. The interpersonal skills is crucially important. And then you always ask yourself these questions that are written now in the rectangles. How should I talk to this patient? Why do they think they're ill? You are asking all these questions in your mind. Why is the patient ill, and is the illness part of a pattern, and so on? Crucially important to ask those questions to establish a good doctor-patient relationship. And here we see this doctor, there's a lot of them. There is no big table coming in between the patient and the doctor, as we too often have patients sitting on one side of the table. So in my office, for instance, I sit here and the patient sits right at the edge of the table. They don't come on the other side of the table. So we are very close, and I can just move my chair and I'll be just like that, directly talking to them, looking directly at them, using hand movements, making them as comfortable as you can so you can hear their story. The whole structure of medicine is based on the assumption that the physician have the current information and patient stupid. The bottom line, however, is the consumer now have the information they can get in the internet here. Once people start getting on the internet, you have to be careful. So I always send people now on the internet, and I have a paper I write all the time what websites they should go to, because if they just Google their problems. So I write down either the symptoms or the problem that I have diagnosed, and they have to go home and research it. Either the children would do it for them if they didn't, and would talk to them about it, and they come back to see what they have found and what they think. Now, previously, I used to give everybody handouts, but I stopped doing that now because everybody has some internet connection. Plus, here near to me, I have a library where anybody can go and get connected, and the librarian can help them get the information. And here it is another doctor-patient relationships again. Smiling, touching. Touching is crucial, and that is why this COVID thing is stupidness. We can't touch much, but I'm still doing it in the office and smiling, but you have to move your mask for them to see you smile. Crucially important in primary care medicine. Attempts how I can teach students to enhance the relationship, to get closer relationships with patients. I could teach you communication skills, touching, looking, being close to, arranging the chairs in the office. But what we do too is role play. During medical school, you might have the chance of playing a patient. And the role play gives you some empathy as to the patient's position. So you understand the position you're in. How you enhance relationship if you have a student who just don't like people. I always remember a class I had, and when I finished the class years ago, a girl got up and said, "Dr. Srinarayan, I don't know what you were talking about, but I want you to know that I cannot stand people." Wow. When she said that, I didn't know what to tell her. I said, okay. She sat down. I had that thing rang in my ears for a long, long while. And then I give them a question in the end, an ethics question. And I read this answer long ago, long time, like many, many years ago. Students is right as the number, so I didn't know who it was answering the question. I read this answer. Well, you only think this person didn't do with the patient that killed them? Wow, when I read that answer, I was real upset. So I traced her number, and it was the same girl who get up and said she can't stand people. Wow. I took it to we had a professor of primary care then. I took it to him. He called in the student. He asked me if I want to come. I said, nah, I ain't do that, no. Anyhow, he spoke to her and so on. But that thing interfered with me, because how can you be a doctor if you like people? Especially, how can you be a primary care physician? Anyhow, I followed her career. She didn't know I was following her. She went into specialize into accident and emergency medicine. But she was changing hospital to hospital, and the problem is she could not have good relationship even with her colleagues. I'm not too sure what happened to her. She went and left the country. I'm not too sure where she is, but she still bothers me. So, medical schools are using to select students. A lot of medical schools, updated medical schools, are using psychoanalysis. It doesn't matter what grade you get in chemistry, physics, or maths, or whatever. To enter medical school, you have to undergo a process of psychoanalysis, where they call you in and they analyze you and ask you why you want to be a doctor and so on and so on. and you have to be you have to pass that examination before you're accepted into medical work. You have to show that you can serve people. Right, so an A in all your subjects doesn't prove that you can serve people properly. So I keep coming back, especially if you're in primary care, that you have to do a lot of introspection to gain deeper insights into the situation and the players involved. We teach that in social events with the patients. But getting doctors from similar contexts as patient helps, then you can relate better to them. I am suffering from kleptomania, doctor. Can I take your temperature? No, this is a Peanuts kind of cartoon where this madam here has difficulty. She's a very abrasive kind of young lady. And the second to last square there said, we are going to have a good doctor-patient relationship or I'm going to slug you. Do you understand that? No, you don't. You can't kind of doctor-patient relationship. You don't demand it. You just let it grow. Because it comes from your deeper self. And the patients would realize it is happening. The relationship is enhancing between you and them over the years. So nothing you can insist on or demand. In specialist medicine is difficult because you don't have continued care throughout their lifestyle. So for instance, this man getting his liver transplant, but you don't know who is coming to do it. Of course he's scared, he wants to know that surgeon. But good surgeons and good specialists, of course, they try to accommodate for this by going and talking to patients before surgery the night before, introducing themselves and explaining what is happening. So the patient know who is going to cut them and so on. That type of care has to continue with special care with hospital doctors. They have to be very careful how they handle that. So your personality, your life story, your worldview, we said all this already, interfere with your relationship. Your sexuality, your perspective and perceptions. We did racial perspective. Learned behavior from childhood, you might change those. And if everybody you make friends with, you're getting past relationship is hurting, you wouldn't want to make relationships with anybody again. So you have to examine that. And of course, your ego. The first type of relationship we're going to deal with is the commonest type found in hospital. It's paternalistic, where the patient is treated as a child receiving care. And as a child receiving care, you don't ask them their opinion or you don't get into too much conversation with them. You just treat them as an empty vessel and you just pour the medical care into them. Now, the medical care you're giving them is good care. I'm not saying you're doing bad care. But you have no relationship with the patient. And you have no good relationship with the patient. The relationship you have with the patient is called paternalistic. If something is wrong with you, like this lady doctor has a paternalistic care for the patient. But you see a halo over her neck, she's a good lady, but she does not know how to have good relationships. And the patient, of course, is scared stiff. Paternalism very common in hospital. And of course, the patient's autonomy is compromised. Their capacity to think, reason, and act for themselves. Patient is just a receptacle of the care. Clinics, hospital, training in professions. If you are being trained by surgeons or specialists who have that type of relationship, you without knowing would copy it. And you would get a learned behavior that is dead wrong. Because you are learning without knowing from your consultants who don't have good relationships with patients. So if you have an arrogant consultant, the one who quarrels with patients, or think he has a lot of hubris, as we said, you without knowing might believe you have to copy that also. But no, don't. Examine yourself, and examine yourself over and over again, because you want to have wholesome relationships as a servant of the people. And sometimes paternalistic behavior comes about without even us thinking about it. So you wonder whether this man was told before, this patient, that he had to be partly undressed, whether he was told before that another person would be in the room while he's being examined, and so on. So paternalistic relationships are too common and they should be avoided. Second type of beside paternalistic, the second one we're doing is consumeristic, and we did that already. The patient is just a consumer, and you just calling them back for money. You couldn't care whether they're good, bad, or ugly. But the worse they get in health, the better for you, because you're making more money. So you want to give them things that they like. Trinidadians like injections. So a lot of GPs get into this habit. As they see the patient, they give them 2 injections. And that pleases the patient, the Trinidadians. They leave the office rubbing their belly under their bottom and saying, boy, that's a good doctor. He gave me 2 injections there. I had to go back this evening for 2 more. All that is kind of stupidity. And that's a consumeristic relationship. Contractual is what you get when you sign a contract with the region and so on. And when you sign this contract, only the basic requirements are there. And if you keep to that, you'll have a contractual relationship. So according to the letter of the document you sign, you don't get into further things. You don't enhance relationship. You're there because you get to be there. End of story. So contractual is common in managed care situations, consumeristic in private practice. Patient has more control, however, in consumeristic relationship, because they could tell the doctor what they want. And the doctor is always catering to the wants of the patient, never to their needs. That is real trouble. Contractual now is managed care. What in heaven's name is managed care? Managed care is very, very common in, say, in the States. Over 90% of patients are looked after a managed care system in the state. What is this managed care? You have to know about it. It is patients who have health insurance. The health insurance you go to the doctor and the insurance company pays for your visit. Now, insurance companies over the years have found that people with their insurance, they have to pay too much for too many doctor's visits, because they keep going because they don't have to pay the doctor, so they keep going with this insurance form all the time. For just next to nothing. If their eyebrow hurting them, they're going by the doctor. The insurance go pay for it. And insurance companies got annoyed and said, nah, they're abusing the system and we have to pay doctors too much money. And doctors, of course, also abuse it. Once they see that insurance form, they keep calling back patients. You don't have to worry, the insurance go pay for it. Go and do this test and that test and a set of blood tests and unnecessary x-rays and ultrasounds and rents and a stupid excessive care that is not necessary and cost the insurance companies a lot of money. So what insurance companies did in America, they started something called managed care, where when you get the insurance, when you pay your premiums and you have insurance from that company, they don't tell you what doctors to go to. And these doctors work together as a group. They work for the insurance company, not for the patient. Not for the patient not giving them money. Insurance company paying them a salary to be a doctor, not paying them for the amount of medical care. And the insurance company now monitors how these doctors are working. Like if we have a group of 4 doctors working for insurance company and one doctor is referring 30% of their patient to the hospital, whereas all the others referring an average of 2 to 5% to the hospital. The doctor that is referring 30% of their patients to the hospital, of course, is costing the insurance company too much money. So they will call that doctor in and they would say, why is your referral rate is so high when patients see you, it is costing our insurance company too much money. Whereas the other doctors who are seeing the same kinds of patients have a far less referral rate. So this doctor might get vexed with the company and say, hey, I am better than all of them. I took my exams and so on. I am concerned with the patient and this and that. I know my medicine and them doctors and so on. So the insurance company will say, well, good that you're bright and we'll keep you in the system. But we call you also to tell you that from now on, if you could keep your referral rate to less than 10%, you would get an extra $2,000 in your salary every month or $5,000. Say what? The company say, yeah, we have that policy, but the other doctors are getting the extra. So this doctor will leave their cousin and get it on. He might leave the job. But if he keep the job, he will try to keep down his referral rate. And he might drop it to less than 2% too. So that is how you manage the care. That's called managed care. And we did this, the wounded healing, remember? To have a good relationship, you have to be a wounded healer. Healing is more than getting something cured. Healing is total. So when you cut yourself, when your mother hug you up and kiss the wound and thing, that's healing. Curing is when you just put the BNT in your ointment and then tell them to go their way. That's curing. So a person who heals is what the primary care doctor should be, somebody who heals. And usually it's wounded doctors, either physical or mental wounds. So you have to examine yourself. We did that. This is a doctor who is a wounded healer. And this again is the wounded healer concept, very important in doctor-patient relationships. The important thing here that I didn't mention is that when the doctor healer here on the left, looking after the patient on the right, the doctor has a wound, that part of his body that is shaded there, and that helps him to have a healing connection with the patient. But the important thing to remember is the patient has a wound, yes, but they get healed by that doctor. And the patient themselves, although they're not qualified in medicine, that patient can be a wounded healer for others. Healing, wounded healer. So I have a patient who comes to me all the time, a young girl. She was diagnosed with with insulin-dependent diabetes, infant diabetes, juvenile diabetes. She was on insulin. She finished her university. She got her master's and so on. Very bright girl on insulin. But then suddenly her kidney shut down, both kidneys. She couldn't go on, continue to work. She had a master's. Come by me very, very distressed and on dialysis. And then she decided to use the dialysis at home, peritoneal dialysis. And then a year or two ago, she got a heart attack. So she now had a heart problem. And she's still in her 40s, early 40s. One day she came to me. She comes to me all the time still. And she said, Dr. Sunarayan, I started something. I said, I have to tell you. I said, what you started? She said, I now have a little place at home where I'm calling in everybody who have diabetes. And I'm showing them how to use the machine, where to buy it, how to use the strips, how to monitor themselves, when they have to do their blood tests. And I'm giving them advice, and they keep calling me if they're having any trouble. She said, this is helping her, and she's now helping others. She has become a wounded healer. She's not charging. She's just doing this voluntarily. And I congratulated her and tell her that's very good. And she said, of course, if I run into any complications that come into you, I said, for sure. But she is now a wounded healer. And the patient can also become that person. Okay, so we did paternalistic. We did consumerist, we did contractual. Default. Default is trouble, because default is when you have a relationship with a patient outside of the consultation, and the patient now come to you as a doctor within the consultation, and you have to change the relationship you have before to one that is now doctor-patient. It might be difficult. So, if your girlfriend come to you now, both of you are girlfriend, boyfriend for years, but she suddenly comes to you as a patient, you might have difficulty. Is how do you now tell her that she's too fat without interfering with the previous relationship? So you could have a relationship, you could tell her to keep coming, but it won't be one of the fault when you're not getting anywhere. Two of you just talking and staring into each other and don't know what to do. This also happens when you're looking after close relatives. Default. Could happen. Make sure it doesn't happen. If it doesn't happen, well, you continue looking after your relatives. Mutual is what is recommended in general practice. Mutual is when the power is more or less equal between the patient, and the patient can free to talk, you are free to talk, and you have a good relationship. So that's a good relationship to have. Collegial is not so good, because collegial is where you treat the patient as if they're your friend in the road or something, lime together and so on. And you're very dismissive of them and dismissive of their complaints. And, yeah, you'll be all right, you'll be all right. And that's the end of that. You're carrying on a collegial relationship that might not be good. Engineering happens very often in hospital, where the patient is only seen as a science problem. And you treat them with the science. Like, you know how to build a bridge, engineer's job, you follow that and you build it. You know how to look after a patient with heart disease, you follow that procedure and you do it. That's engineering relationships. Not very well recommended. Priestly is a little trouble too, because priestly is when doctors start to see everybody as good, bad, and evil, and so on, and they want to pray with them and say this and say that. I say you mustn't pray, but then go to the church now. Do use the office with your MBBS degree to get into that. You understand, when you have MBBS, it's to practice Western scientific biomedicine. You understand. Over time, to the right, relationships have changed over time. Good relationships between doctor and patient is always know that the patient is vulnerable. You have a vulnerable patient in front of you. So you have to be very careful when somebody is vulnerable and in front of you. That means you can do them harm. And I always remember my consultant when I was doing internal medicine. My consultant told me, say, Tennyson, one thing you have to be careful about. I said, what's that? When you hold a pen to write a prescription, be very, very careful what you write there. Because instead of doing good, you can do immeasurable harm. So I always get right when I pick up a pen to write a prescription now. And what I've done too, I've made my prescription pads very short. So I don't have to write a set of things. Patients are vulnerable. Always remember that you have an inherent inequality in the consultation. And that would make your good relationships, because you have to explain. You have to tell them what is wrong with them. You have to show them. You have to direct them, because you know the medicine and they don't. Or that's why they come to you, because there is an inherent kind of, in the knowledge of medicine, inherent inequality. Now, so I have people coming to me, all right, now I have a physics professor comes to me all the time. But he knew about physics, I can't know. It's too way above. But he comes to me for medical science, and we talk. He understands when I'm explaining to him and so on. Fiduciary character, what is that? What is fiduciary? Anybody knows? It's trust, character of trust. You always trust the patient would do what you tell them, and they trust that you would give them the correct knowledge. Fiduciary relationship is a relationship of mutual trust. Non-proprietary knowledge. The knowledge you have is not for sale, like consumeristic relationships have proprietary knowledge. You cannot have consumeristic relationship because then your knowledge is proprietary, is your property to make money from it. No. The knowledge you have as medicine is non-proprietary. So even if somebody stops you in the grocery and asks you something, like, answer them now. You understand? That is knowledge to be given away. And very often, you are the only doctor they're coming to. And you have to realize you have a responsibility because you might be the final person they're coming to. And you have to be careful. Final common pathway. No, we know this person. I don't know if you know this person, but I know him. He was the doctor to Michael Jackson. And he had a consumeristic relationship. And he ended up giving Michael Jackson a drug to sleep. And that drug was an anesthetic drug, using anesthesia. And Michael Jackson died because of it. He got into problem because of his consumeristic relationship. You know, he's a Trinidadian, and he's trying to practice medicine in Trinidad now. But his consumeristic relationship got him into real deep problem. Now, to have a good relationship with patients, the virtues you have to have as a doctor. We said something about virtues already, remember? But one of them we didn't mention is unconditional positive regard. That means you have a positive regard for the patient, unconditional. And that is strange. And that is difficult sometimes. So if you cannot have an unconditional positive regard for the patient, well, tell them to come back, go to another doctor. Or get another doctor to see them and so on, because you're having problems dealing with them. So if you saw this man pelting down your house the night before and breaking a few of your louvers and glass windows, the next morning he come to you as his doctor telling you his wrist hurting him, how you could have a positive regard for him because you saw him what he was doing? You cannot have an unconditional positive regard. You're having difficulty. So you just tell him to go to another doctor for that wrist problem. Genuineness, we mentioned some of this. Genuineness is you have to be giving two levels to this. The medical information you give, as we said, must be what is shared by other doctors, genuine information. And you always stay with the Western scientific biomedicine. Right. Don't get into noni juice and so on. You know, this noni juice that was brought into the country was brought in by a doctor. Right. And they have doctors right now doing a sort of dotishness. They practice. I know one that did very well in medical school. And right now he's doing total rubbish in his office. He ever set a computer line and he has made the patient put their hand in one computer and the next computer down the line will tell him what's wrong with them. He's doing complete rubbish with his medical degree. You have to give genuine knowledge, Western scientific medical knowledge that you learned in medical school. But there's another level of genuineness. And that level is, are you as a doctor a genuine person? So, if you're advising somebody not to smoke, but while you're advising them, you're smoking as a doctor, or you have an ashtray that you use on your desk for him to see, how in heaven's name he leaving you and stopping smoking? He said, that doctor crazy, or he tell me to stop smoking, and look how he's smoking. Don't go there. That doctor is not, you are not being genuine, that doctor. That person would consider you as a non-genuine person and wouldn't, you might not come back. So I always remember a lady coming to me. She said, Doc, I changed my doctors, somebody tell me to come by you. I said, why change the doctors? It's too far for you to come here. No. I'm not going back by that man. I said, why? She said, Doc, I run a bar. And one day my doctor came in. For years he was my doctor. And he was drinking with his friends and talking loud and so on. And she run the bar, she was making money out of him. And I see how he getting on, and I tell my husband, I'm not going back to that man. I remember that story well because I knew the doctor too. And he was not genuine. What he's advising people, he's not doing. Empathy, we know about that, putting yourself in another person's shoe. Beneficence and trust is doing good in the fiduciary relationship of trust. Trust is a fiduciary relationship. Always reassure. Right, I think that's the final slide. Now I will leave some time for you to talk to me if you have any questions or query. Wow, nobody has any questions now. That is great. You have anything you want to explain further? Okay, well, you will get the slide with the. You're hearing me? Are you hearing?
So hearing you. I
Right.
think everybody is. I
Okay,
think
well,
some people responded in the chat box,
I'll
but
have to
it
read that
seems that
for next time. But
everybody is okay.
everybody's all right, is it?
Yeah, we're okay.
No, you
Thank you
have to
very
get
much.
this. Wait, you have to get this PowerPoint. You have to get the first two also. But the second one you say you didn't have. You ask the community for it, the community department.
Yeah, I have the second one and we have this one, but I didn't get the I have to get the
You
second
have the
one.
first, you have to get the second one, yeah.
Yeah, I have to get the
All
second
right,
one.
so we're going to meet Thursday again
Okay.
with this virtual thing. I prefer to teach people face to face. But anyhow, wear your mask when you come back, eh? But not the same one, you have to wash it out. Wash it out because the virus getting in. I'll
Yes.
see you all next week.
Okay. Thank you very
Thanks
much.
for listening and thanks for
Yes,
listening.
it was a very lovely class. I think the whole class could agree. We
Okay,
haven't
thank
had a
you.
class like this.
Oh, you're seeing my
Right.
picture, weren't you? It's real
Yeah.
handsome, you know. Wow. A lot of you were not paying attention. You were only looking at my face. I'll see you all next week.
All right. Take care.
Bye.
Bye bye.
Bye. Mania, come and switch off. I don't. I have to keep calling you. This time it's sticking. It was sticking at me.
Yeah, it's giving us a trouble. No, I mean, like when you press share screen, the thing does give us a trouble. So press stop the share screen, so press stop sharing. Right. And then, yeah, the thing giving a whole set of trouble, we only,
Are you seeing the option to stop recording by chance?
mhm.
Sit 2 months.
Hi, Karen.
Oh,
Can you hear me? Okay.